Let's get going. I want to start off with a disclosure. I wear many hats. I am medical director at the University of Minnesota Blood Bank Lab. I am also the chief medical officer for the AABB. Nothing that we discuss today as part of the ACBTSA should reflect upon the AABB positions that the AABB or the University of Minnesota hold. These are just specific to the ACBTSA and to me. I'd like to give some quick history. During the 57th meeting of the ACBTSA, a live meeting in DC, we looked at a large series of recommendations, which we did not have time to fully discuss. Since the close of that meeting and the beginning of this meeting, we have had emails about these recommendations. I split them into two sets and sent them out to the ACBTSA committee members for their comments. I then incorporated their comments to create a, in some cases, slightly new version or different version of the recommendations. That is what we will be looking at today. Those recommendations in that revised form went out for public comment, and we received comments back from joint comments from the AABB, America's Blood Center, ABC, and the American Red Cross, the ARC. And I'd like to thank them for those comments. All of their comments have been carefully considered and incorporated into what may become a revised version of the recommendations. We also received comments from the FDA. I'd like to thank Ann Etter, who is Director of the Office of Blood Research and Review at CBER. I'd also like to thank Nicole Verdun, who is now the Super Office Director of the Office of Therapeutic Products at CBER. They both have shown a tremendous commitment to blood availability and safety and have helped us with insightful comments for the recommendations that the ACBTSA put forward. So thank you to everyone who has looked at these recommendations, provided comments and discussions. We're going to go through the first set of recommendations. There are 4 recommendations in the first set. We will have 15 minutes to talk, in which I will be talking the whole time. We will then have additional time to discuss the recommendations, possibly wordsmith them, and hopefully vote on all 4 of them. We will then take a brief break and then move on to the last 6 recommendations, where we'll follow the same sort of schedule. So the 4 recommendations that we're going to work on today are outlined here. The first one, which we discussed in the 57th ACBTSA, is about blood products and related tests that they should receive priority status for transportation during emergencies. To enact this recommendation, there would be a revision of what is known as the ESF number 8 document, which is a document the US government uses to help prioritize various measures during an emergency. And so the second recommendation says, while ESF number 8 is being revised or examined for priority status for transportation, they should also just look at any other blood-related matters within ESF number 8 and adjust those appropriately so that blood consistently receives a high priority status during emergencies. The third recommendation is consideration of a new payment model during long-term emergencies. And the fourth recommendation is a call for additional funds to support increased donor activity. So let's wade in. Recommendation number 1. The committee recommends that during national and regional emergencies, government resources are made available to assist blood collection centers with the transport of blood samples and other key supplies that may be needed in affected areas of the country. The Emergency Support Function, or ESF number 8 planning document, should specifically incorporate this provision into their planning function. This may be done with an annex to the ESF. So if you recall, during the 57th meeting, we actually voted on this recommendation, but it still needed to, and there was unanimous, it was approved unanimously. However, the recommendation needed to go out for public comment, which it did, And we received one comment from the joint comments of ABB, ABC, and the Red Cross. And they said our organizations support this recommendation. So there were no further changes suggested during the public comment period. Again, I'm going to go through all 4 recommendations and then we'll have a chance to discuss and vote. The second recommendation simply says the committee further recommends an analysis of all required blood supply functions with cross-reference to the ESF number 8 planning document to ensure that all functions are appropriately covered with an annex to the ESF. And once again, the joint comments from ABB, ABC, and ARC note that their organizations support this recommendation, so no further changes have been made to this recommendation. Recommendation number 3 is a little more complicated. I'm going to begin with a brief preamble to give background. In the 2020 report to Congress from the ACBTSA, it was noted that the current payment model for blood components led to dramatic loss of revenues, operating margins, and capital required to maintain and replace the current infrastructure. This, in turn, limits blood collection centers' efforts to plan for emergencies where surge capacity is required. So as a result of this, recommendation 3 originally said, the committee therefore recommends that the Zika payment model be used during long-term emergencies to support the collection and manufacture of blood components to allow for a minimum 10% increase over baseline usage during emergencies when surge capacity is required. So there have been 2 major emergencies in which the government stepped in to help support the blood supply. It was during Zika, when the government helped with the blood supply in Puerto Rico, and there was also a time when BARDA helped support the blood supply during collection of COVID convalescent plasma. That's considered the CCP model. And in the recommendations original language, we discussed CCP. However, during internal comments within the ACBTSA panel, there were some members of the ACBTSA that said we really shouldn't be using the CCP model, we should be using the Zika model. So I'd like to just mention the Zika model is an alternate payment model that was used to provide blood to Puerto Rico during the Zika virus pandemic, when BARDA, under the Administration for Strategic Preparedness and Response, or ASPR, provided funds to collect and supply necessary blood components. This payment model was highly successful, but there was also the CCP model that was negotiated during the COVID-19 pandemic. That payment model was used in which BARDA, under ASPR, provided funds for collection of CCP, and it was also highly successful. BARDA also established the contracts with the American Red Cross and Blood Centers of America to collect and supply blood components to Puerto Rico during the Zika virus pandemic. Okay, so we had these 2 models suggested as a way to consider recommendation 3. But then we received these joint comments from ABB, ABC, and ARC, and this goes to 2 slides. ABB, ABC, and ARC support the Zika payment model, but encourage expansion of the model to number 1, ensure blood establishments are not collecting blood at risk and are receiving necessary financial support through cost recovery funding, similar to the collection and distribution of COVID convalescent plasma. And 2, establish funding for local public awareness about the need for blood donors. The comments went on considerably longer, but I excerpted and just left this, which is a busy slide, so I apologize, but the comments continued. Throughout 2020 and 2021, BARDA under ASPR provided cost recovery funds for collection of CCP through contracts with ABC and ARC. A key element of the CCP model was the provision of cost recovery funding upon collection, not distribution. By providing cost recovery directly to blood collectors upon collection of units requested as part of the CCP surge, blood centers were able to invest in the collection of CCP even where the cost of collection would have been otherwise prohibitively expensive. The shift in the model to cost recovery funding upon collection resulted in significant increases in the level of surge witnessed throughout the country. Another essential aspect of the CCP model was the provision of funding for local public awareness about the need for a surge in blood donations. Availability of donors will likely be the greatest threat to long-term surge capacity, and it is critical that message be tailored to local communities. During the COVID-19 pandemic, such funding for local awareness was distributed through an Other Transaction Authority, or OTA, with ABC, and resulted in a sustained 244% increase in collections compared to previous baselines. So, at the top of this slide was the original version of recommendation 3, as I already read. At the bottom is a revised version suggested by the joint comments from ABC, ARC, and AABB. And I'll read that now. The committee therefore recommends that BARDA under ASPA negotiate contracts directly with blood centers during long-term emergencies to support the collection and manufacture of blood components to allow for a minimum 10% increase over baseline usage during emergencies when surge capacity is required. The cost recovery shall be for collection rather than transfusion of blood that is deemed essential during the emergency period. Now, although we're going to discuss this further, I just would like to say that I like this because I found referring back to the Zika payment model versus the CCP payment model to be confusing and could lead to ambiguity. Whereas this recommendation is broader and will apply to all situations. So as I said, there will be an opportunity to discuss this at length after I finish just going over the 4 recommendations in this set. And the last recommendation is the committee therefore recommends that Secretary Becerra fund additional public awareness campaigns, including funding for data analytics to increase the donor pool and determine effectiveness. If you remember, during the 57th ACBTSA, this recommendation there was a slightly different version. There was considerable discussion that we had not included funding for data analytics, so that was added in this version of the recommendation. However, the joint comments from the AABB, ABC, and ARC go on to say that they commend HHS for their support of the blood community during COVID-19 pandemic and for their efforts in carrying out the congressional requirement of a public awareness campaign for blood. While we remain supportive of the campaign, we believe the best use of any future federal funding for public awareness for blood donation is best directed locally. As stated above, funding for local awareness distributed directly to blood centers as part of an OTA between the US government and ABC during the COVID-19 resulted in a 244% increase in collections. So taking that into account, the revised version includes the sentence in red. The committee therefore recommends that Secretary Becerra fund additional public awareness campaigns. These funds should be distributed to blood centers for local campaigns. Funding should also support data analytics to increase the donor pool and determine effectiveness. Okay, so those are the 4 recommendations that we now have time to discuss following, and that will be followed by a break. And I'm sorry, I thought we were going to look at all 4 recommendations on a slide.
Yes, on the whiteboard. Yes.
Okay, I'm sorry.
Okay.
So time for the whiteboard.
No problem. So I think if you, are you still sharing? If you stop sharing, then I can share my screen.
I'm not sure that I have control for that.
Okay. Yep. I think we're good. I think I can do it now. Let's see. Let me just pull up this document.
So I would just like to remind, while Kat is doing that, and Kat is the wizard who is going to guide us through this and help with the wordsmithing that occurs, I'd like to remind everyone that this recommendation number 1 was already voted upon unanimously and approved, and that comments did not, there were no comments. So it can remain as the same recommendation we originally voted upon. So unless there's further discussion of this recommendation, I would like to go for a final vote on this recommendation. I'm taking your silence to be assent. You have
You have the
Susan?
motion? Do you have the motion or?
I'd like to move that we vote on recommendation 1 as written here.
I second?
Do we need a roll call, or can there be a show of hands?
It can
Jim?
be a show of hands.
Okay, if everyone will please use their, either raise their hands on the screen or use their little yellow hands. Please vote on this recommendation.
Claudia, and just a reminder, there's 17 voting members. Voting members are the special government employees and the representatives. The ex officio members are not voting.
Okay, thank you, Jim, for that reminder. All those against? We have moved forward. Thank you, everyone. Kat, if we could, thank you. Let's move on to the second recommendation. And this is simply, while the government is working on ESF number 8, any other blood-related matters would be also considered for high priority status. This is now open for discussion.
Move to approve.
Do I hear a second?
I second.
Thank you. Okay, if we can just please vote on this then. All those in favor? And is there anyone opposed? I believe that this vote has passed. We've done twice as much as we did back in DC. Thank you, everyone. Okay.
That has connotations, Claudia.
We can use that as we wish, right? Now this one I do not expect will go through quite as quickly, but thank you, Kat, for scrolling to the original version and the revised version based on joint comments from the AABB, ABC, and ARC. If everyone would just look at that, I'd like to open this up for discussion.
Looks like Josh has his hand raised, Claudia.
Thank you. Josh, why don't we begin with you, and then we'll go to Susan, then Sridhar.
Sounds good. Thank you for that. I just, because this is my first meeting and I have not had, due to some administrative issues, I was not a part of the meeting last year, nor were any of my colleagues, but I just have a real quick clarification question, I think, for this. Is there some type of definition or understood usage for long-term emergency and how that's different from another emergency?
That's an excellent question, and no. That's the recommendations are meant to be, or are in general, broad, and we have to leave it to our government colleagues as they implement the recommendation, once they accept the recommendation, to implement it appropriately. And I'm not sure how that important question will be ironed out, but I don't know that it's up to us at this point to do so. But I leave that open to the panel to decide if we want to wordsmith it to include a time limitation or some sort of definition of long-term.
My take on that is that you basically have an infinitude of possibilities with which you can define something like that. I was just curious if it had been a convention of past usage where that had been defined before, but I'm afraid that if you spend a lot of time wordsmithing it, you probably won't get too far, just because of all of the possible implications that there might be.
Yeah, unfortunately, I agree with you. Susan?
Yeah, thanks. It's sort of a terminology question, and maybe you addressed it and I missed it. The term cost recovery is, I think, typically used when for an investigational protocol, and I think that applied in the CCP situation. I'm wondering if we could maybe clarify the intent of that, the last sentence. I think we're talking about the reimbursement. The reimbursement is based on collection and doesn't require transfusion. I think that's the intention, but I'm worried about the calculation of costs, or if we're talking about the distribution of reimbursement. I'm not sure exactly what we're talking about in that last sentence, but I'd like to make sure that our intention is clear, that it doesn't apply only to investigational situations.
Overall, Susan, I agree with you that the idea of cost recovery, I believe, does mean reimbursement, because I think that was how it was used during CCP. But if others on the panel, this language evolved via the working group that helped develop these recommendations, not all of whom are on the ACBTSA panel, but most of whom were involved in blood centers or in the blood world in some way. BARDA was also part of that working group. If the panel believes that we should wordsmith and say the reimbursements shall be for collection rather than transfusion, I don't have the expertise to say.
Yeah, or maybe for collection and manufacturing, because that's what's referred to in the first sentence. There's a cost for the processing, not just the collection.
Does anyone have anything against using the language of?
Claudia, this is Stacy. I think the benefit of modifying it is that then it isn't about the research part. And I think what we're trying to accomplish is that in a surge capacity, you want the blood centers to collect at risk, which is basically what you're trying to do at this period. So without all of the experience of this WISE group on government language, I think for the blood centers, it becomes clear what the purpose is.
Thank you, Stacy. I think that's helpful. Sridhar, then Cassandra, Jed, and Ray.
Yeah, I just wanted to make, I guess, a couple of points. The first is maybe we should call it public health emergencies rather than long term. The other issue I think is a little bit more, I guess, just based on my own observations, kind of inside, but not really inside, because I'm not. But you know, in the Zika model, I don't remember if there was actually like a markup above the actual cost of the red cells and platelets. Jim Berger might remember that. I also don't think that the negotiation happened directly with blood centers, and I don't know why you're saying that here, that there should be specific blood centers with which there's negotiations. I mean, I think that the way it worked then was that there were contracts to ARC and then the ABC, and there was no actual. I mean, there's 100 blood centers in the U.S. I don't understand how that would be fair if BARDA was told to pick one or two of those and negotiate directly with them. So I guess I'm wondering why there's a minimum cost increase that's being recommended, why we're saying BARDA should negotiate directly with blood centers. And yeah, I mean, I think those are my two points with this. I mean, and I think that part of this, I think my skepticism with this recommendation comes from what I observed with CCP. I mean, that was a product that had no known efficacy at the time, that BARDA was paying several-fold higher for those plasma products than what a plasma product actually costs in general. And at the end of it all, we had hundreds of thousands of plasma products that were transfused. And I'm not sure there was a clear benefit for a lot of them. So I think where I have some concerns here is with the language to negotiate directly with blood centers, with a recommendation that they should pay more for these products. So I don't know. I mean, I'm not sure that this is necessarily a recommendation that I would support. I mean, I'm not voting here, but I don't know if this is in general a recommendation that I would support because of those reasons.
So thank you, Sridhar. We heard from several members when this was originally couched as a CCP model. Several members brought up the same your same first point, which is that Zika, I believe there was no additional charge to the blood product. It was simply the same amount of money that was usually charged. Whereas CCP, there was a difference in price for a normal unit of plasma, and that was the reasons for that were based on that this was, even though it's the same product, it was labeled differently, tested differently, treated differently, and that new line required money and time to cover that extra work. However, that went back and forth, CCP model versus Zika model, and Zika model won based on the number of comments I received. But when ABC, ARC, and AABB commented, I removed Zika and CCP, but the thing that remained from the CCP model was the negotiate contracts directly. Now, if we do not have that option in there, we would need to have some alternative, how that would work. And I'm not sure what that is, but if I open it to the panel to offer suggestions before we move on to Cassandra's question.
Hi, Claudia, this is Anne. I'm sorry, I'm going to jump the line because my comment is related to this. I'm sorry. But just to add on to Sridhar's comment, the Zika model, I'm confused on what is being recommended. The Zika model reflected a situation where Puerto Rico's entire blood supply was at risk. Blood could not be collected, Zika was prevalent on the island. There weren't enough, there wasn't a screening test, as I recall, and I'm struggling to recall the details, but their entire blood supply was at risk. That's very different from, I don't understand how the terms Zika model and COVID, convalescent plasma model are being used. They're very different. So I think at the very least, you have to clarify what it is you're talking about. Are you talking about more like a Zika model where you need to consider a very local and very severe shortage in a local region versus a convalescent plasma quote model where it really was an investigational product, and if nothing else, we've learned a lot of lessons and considered how we might have done things differently in that regard. So I just don't understand the recommendation. So thank you. I apologize for jumping the line.
No worries.
Yeah, sorry, can I jump the line again just to add to what Anne said about this? Also in Zika, because we actually looked at, like when that whole Zika thing was going on, OASH actually sent me out to Puerto Rico. So I went down to Puerto Rico. We did this big survey about how much blood they would need. And then I reported back to OASH. And from what I understand, the ability to mobilize the amount of blood that Puerto Rico needed wasn't really that big of a deal in terms of the elasticity in the blood supply. So like there wasn't like some big shortage on the mainland. It didn't seem to me like it was really, I mean, I think it was a heroic public health gesture to get all that blood together and move it to Puerto Rico. But I just didn't get the feeling that there needed to be some big markup with the price of blood there.
So Claudia, this is Stacy, and I wonder from the blood provider perspective if this would help. And I'm not talking about the price here, but for me with the Zika model, what you're really getting at is that's a more isolated situation. So if you think of Puerto Rico, yes, it was all of Puerto Rico, but what we really needed to do was to be able to have a system to quickly reimburse for the other blood centers in the rest of the country, covering Puerto Rico's blood collection, which is basically what happened. In the surge capacity, I think what we're saying is that there needs to be a model when every area of the country is impacted. And so at that point, you're asking people to collect at risk because you don't know where it's going to. And I think it's less, and I didn't read the minimum 10% increase. I might have read it wrong. I read that to mean a minimum of 10% increase in collections, not in fees. So I think what we're saying is that we would use this in times when the surge capacity that's needed is a 10% increase in what's normally being collected in the United States, right? So that it's a very big ask, where what happened in Puerto Rico, if we looked by percentage, was probably really just, less than a 1.5% increase.
So before we turn to other questions, just to put everything together, I wasn't entirely comfortable with Zika versus CCP model. However, this was a working group. We put this recommendation together, and I was pleased when the joint comments eliminated the need for that. And Stacy, I think that you have gotten to the heart of it. It's that during an emergency, there needs to be a mechanism for funding an increase in blood collections, and that those blood collections the blood collectors are at risk, and that should be part of the negotiations. Who makes the negotiations? I don't know whether we should decide that, or that should be generally decided after we make a general recommendation that there simply is a recognition that during emergencies, there should be a different reimbursement model. I'm going to, I hope that answers your question somewhat, Anne, and addresses your comments, Sridhar, and thank you, Stacy. I'm going to turn it over to Cassandra.
Yeah, and it sort of chimes in with what everybody's sort of talking about, which is the definition of surge capacity. It seems the way it's sort of dangling at the end of this sentence, but really, it says during emergencies when surge capacity is required. Well, what is surge capacity? And who gets to decide that we're at a need for surge capacity? And then where do we go with that? And, this is where when we need 10% increase, because we're not talking about necessarily, we need to definitely reimburse, and it does cost more money to surge, whatever it is. We got to figure that out, and it needs to go to the blood center. But I do think that we as a community need to decide what that actually means and where it needs to happen, because we can move blood around the United States. So does every single place need to be making the blood for everybody? And I think it's important, because how we marshal the resources, if we give it to every single place and it's not necessary because of what is happening. So I could see this being picked apart a little based on that. And I don't want it to fail, because I think that what happened in Puerto Rico is one example of an emergency that could happen. And what happened to all of the United States and with CCP is another kind of example. but there could be something on the mainland that makes a region of the country incapable of making and incapable of, having enough resources. So part of this is being able to distribute and move blood and being able to focus it. So I just feel like there's a lot of vagaries in this that could make somebody say, we're not going to do this for you because it's just too vague. That's just my overall feeling.
No, I get what you're saying, and I agree. I don't want to leave this too vague so that it's used inappropriately. I don't know whether we will achieve this today, to be able to insert language to say, if normal distributions and redistribution, if normal collections and redistribution of the available blood supply is insufficient, and there is a need for a 10% increase in collections in order to meet the current demand, then this will go into effect.
Something like that. That sounded, that was much more precise.
Did you get that, Kat? Because I don't know if I'll be able to say it again.
It's recorded.
It is recorded.
I just have another question about that. So if blood centers, if there's projected to be a 10% increase and blood centers collect that, I mean, they still get reimbursed for that, right? So why does HHS need to pay for it?
Well, they don't. I mean, that the hospitals are who gets paid, and then the payment goes to the blood center. It's very few times where there's actually money put into the blood center that actually they get to use that money to do the things they need to do. It's a very circuitous and removed route in which they get the money. And that's
but they still get the money though, right, Cassandra?
Not necessarily in the way that they need to get it. It relies on a lot of different things. So it's not as straightforward as it would. You'd like it to be that way. That sounds great. But really, the blood centers have no power here to do anything, but they get asked for a lot of stuff.
For
So if
instance,
you get a surge capacity and all of a sudden you did extra recruiting and extra drawing, there's no guarantee that all of a sudden it's not needed and it outdates.
Yep.
Yeah. Sorry, Diane, go on.
That was it.
Yeah, the unfortunate truth is that during emergencies, we have a surge in donors, and the blood centers collect a lot of that blood, and then some of it goes to waste. And blood centers do not receive reimbursement for those extra collections because they were not transfused. I think the devil in the detail here is to make sure that we do not overuse this recommendation. We only use it when there is a clear need to increase the number of collections to meet a long-term surge in demand. But again, as Cassandra and others have said, what does that actually mean? I don't know if we'll reach that language today. Jed, you've been very patient.
Yeah, it is good to review history. Post 9/11, post Las Vegas shooting event, there was a surge in donors. After COVID initiated and we had a wonderful public health commentary about the importance of continuing to donate, we had a surge in donors. But memory of donors is really short. And within 2 months after onset of COVID, the bolus was gone, and now we were short. So I think it really is up to a working group like BARDA working with, Circulate, as you've heard today, to be having real-time monitoring of inventories and only implement when there truly is ongoing need. So it needs to be need driven. The second thing is, as my presentation last summer, we have tremendous economic forces minimizing inventory, minimizing waste, all of which is great for a steady state consumption, but a disaster in disasters. We need to have mechanisms to ensure surge capacity, and no blood center in their right economic mind is going to have extra staff, extra resources on hand. So if we want to have surge capacity, we need to have preparedness planning in advance, and that includes some mechanism to increase. As Claudia said, the devil is in the details. The last thing you want to do is to and give economic incentive for blood centers to collect more AB red cells, right? So I don't think we should be wordsmithing here in a short recommendation. We should be empowering BARDA and the negotiating organizations in that negotiation process to be asking for what they want and need, because that's going to change depending upon the specifics of the emergency. And if you want to change negotiate with blood centers to blood collection agencies, and that way it can be a model very much like the skin that you've heard about this morning. And so you're not saying that you have to negotiate with every blood center. Create a mechanism so that this can happen in advance. What you don't want to have to do is create infrastructure after the emergency happens. That is what we're trying to avoid.
Thank you. Ray, and then Anne, and then Lynn.
My comments accumulated as the discussion went on. Just a couple of points. I think the purpose of the revised version, which takes Zika and CCP out of the model, is the way to go. Don't even refer to them. I wouldn't even know what the details or differences are between the two approaches. So I think what you're doing in terms of the revision, it makes sense to eliminate those and take them out of the thinking. There are a couple of things, however, that I think are important, and I agree with what Jed was saying. We just heard this morning about BARDA negotiating with two facilities to provide 5,000 additional allografts in order to address the need for potential burn patients who might require that as a result of a nuclear event in the United States. And that was based on some kind of models that they had for how many survivors there would be and what the need would be above and beyond what the totals were. Perhaps a decision about what actually constitutes an emergency that would invoke something like this would be handled in the same way. I don't know, but there would have to be some kind of a possibility. I also interpreted the 10% increase not to be an increase in price, but to be an increase in the amount of blood availability that might be required in one of those kinds of situations. Does it need to be 10%, 20%, 30%? I don't know if we'd have the answer to that. Just like someone asked this morning, why 5,000? Well, there was a model that dictated that that's the point at which that they were going to target, and BARDA went about setting up the agreements with two centers in particular to be able to provide that amount. I think the question about cost is a good one, though, because in at least the CCP model, I believe there were additional things that needed to be done to those products. You had to do antibody testing on those products that wasn't normally part of titering on those, wasn't normally part of what blood centers were doing. So the question would be if there's, what we're talking about here, I believe, is just the provision of blood products in case there's a shortage, but standard blood products. These are not new blood products, or these are not something that requires above and beyond what the normal processing of those products requires. The question would be, are there increased costs that are associated with increasing capacity of collection at the centers? More staff, more people. I think someone mentioned more outdating. So how you address that implies that it's not just the burden of saying, well, they're collecting more and they're going to sell more product because there's more need. So what reimbursement is required? There are costs that are associated with those, with increasing the collections, which they may or may not be able to recoup. What are those amounts, and what would be the need for that? I think that's what we're saying. That's where you have to support those those groups that are doing the collections in order to meet that need that might go beyond what their normal capacity to provide these materials would allow. Those were my comments. I
Thank you.
actually like the revisions because I think it does provide clarification.
Thank you, Ray. Before, Anne, have you taken your hand down? Or Lynn, are you next? I feel as though I'm hearing in general agreement on things, with concerns over definitions and limitations. And those are not small matters. Lynn, you next, and then Anne?
Oh, sorry, I had not lowered my hand, Lynn, sorry.
Yeah, no, Anne is next. I
Go
will
ahead,
keep
Anne.
us all straight. Thank you.
Well, so thank you for the discussion. And let me just say this discussion is making this recommendation much more palatable. Because when I read this with the inclusion of, negotiating directly with blood centers, a 10% increase in whatever is here, increase in collections does mean, we're willing to increase. To me, I read this as, we'll increase by 10% if we're appropriately compensated. So I think if this recommendation, but in this discussion, I've heard, just to reiterate what Jed said and what Dr. Goodrich said, this recommendation would be strengthened if the concepts of, instead of saying, negotiate with blood centers for a certain increase above collections, because we don't know. I mean, if there's anything we've learned, it should be that we don't know. We don't know what the next emergency is going to hold. So if the concepts of, and 10%, frankly, I mean, just from the data this morning, the variation, those error bars, 10% is nothing. 10% isn't a surge. So I was very confused. But if the concepts of when collections are, put the blood centers at risk, and at risk of, by that I mean, they're not able to meet demands, that whatever investment is need driven and it's put where it's needed, I think this would be a much stronger recommendation. And certainly investment into preparedness would be a good investment. And those are my comments. Thank you.
Thank you, Anne. Lynn, then Stacy, and then I hope we can take time to wordsmith this into shape, because it would be lovely if we can move through this. Lynn.
So I'm, again, the AABB liaison, and have certainly backup in terms of the consideration here. And one of the questions that has been raised, and I also believe that Lou Barnes has brought this up in the chat, is the legal implication of public health emergency and the potential perhaps of it being, if it's included, being too limiting in terms of what we are trying to make sure we're covering with this recommendation. So I'm just putting that out there, and would, want us all to consider, is it appropriate to include it as stated here, or can it go back to being a more general understanding that long-term emergency is somewhat ill-defined? So.
Thank you, Lynn. Stacy?
Patty, the only thing I was going to say is I actually think, and I think maybe Raymond mentioned this, he was wondering how the 10% tied to the 5,000 that we heard about this morning. I actually believe that BARDA does have a number from that same modeling that relates at least to platelets. Maybe Jed will remember this, but I am pretty sure that BARDA spoke at the ABC meeting last March and talked about the surge capacity they needed for a similar event. So if we're needing to get it that specific, I speculate there is that modeling. And I didn't know if anyone on the call knew that, but it does seem like BARDA has done some work on that.
If I remember correctly, and BARDA was part of the working group that put together this recommendation, we did pull 10%.
Okay.
Somewhat out of the air, but it was, I believe, based on BARDA's thinking. Okay. So I'm sort of being very vague because I don't know.
I remember 90,000 platelets were going to be needed in 7 days. And I remember that because it was such a big number. And I actually looked back to see if I had wrote the number down that they had talked about earlier. And on a weekly basis, they had 6,000 platelets. So if you did that, it was a 10 to 15% increase based on where you were on their circulate chart today. So that's probably where the 10% did come from.
As I said earlier, I think it's important that we say that there is that this would only be put into an effect if there is a 10% increase in collections needed because we are not meeting demand, the increased demand of a surge. Can we do you think we have 54 more minutes, and we have one more recommendation in this set, and that's a fairly simple recommendation about donors. I'd like to think that we can wordsmith this into shape, although I really don't want to rush this because it's important. I don't want it to be poorly worded and therefore abused in the future. But I want it to help. I know the first line, negotiate contracts directly with blood centers during long-term public health emergencies or during long-term emergencies. Jed, you had mentioned changing that to blood agencies.
Blood collection agencies.
Blood collection agencies. What do people think about that?
Jen, are you trying to, with blood collection agencies, get to folks like ABC? Or are you trying?
Correct. So, I mean, you could do ABC and ARC.
But is it more just an organization that represents blood collection agencies? So, because that's ABC in and of itself isn't the blood collection agency, but it's representing, right? So I don't know if
it's an aggregation thereof. So blood guys.
Get put in there, blood guys.
Will that also include will that include hospital-based blood collection? Does that fall under ABC? I mean, this is just maybe my ignorance, but or do we want to make sure we include those as a place?
I think when we did this with CCP, ABC represented everybody in the way the contract was written.
Okay.
But I think that's the key here is how do you word that? Because even blood collection agency doesn't necessarily suggest ABC, or the other group that would seem to possibly work would be, I'm going to say ABB, but I know that's not their name anymore, but that group could also function in that way probably.
Would blood suppliers work?
I think blood suppliers encompasses everybody because then there's no specialization. I just want it to be as encompassing as possible so we don't leave anybody out. If we're thinking that everybody needs to be able to have a fair shot, or depending upon where this happens, it might be important.
But will BARDA negotiate separate contracts with each individual, or will there be a uniform contract that is applied for all blood collectors?
I would think that's what you would want, right? Is a uniform contract like they did with the tissue.
Claudia, this is Jim. Just for clarification, BARDA did have separate contracts with ARC and BCA based on what they identified as their cost to not only collect the blood, but also to ship the blood to Puerto Rico.
So in Zika, they were separate, Jim, but in CCP, it was uniform?
That I don't know. I really dealt with the Zika the most. BARDA really did that separately.
On the BARDA skin, it is, we don't know what the Allosource group bid or what pricing they had. I will tell you that BARDA negotiated separately with both.
How about
this is Glenn Ramsey. Maybe the word directly is a little bit too strong here.
How about, and also negotiate a uniform contract that will apply to all that,
There we go.
and I said the to all blood collection agencies, but it would be the blood collection agencies negotiating with BARDA. So I'm not sure that that language is quite correct. With, how about just a uniform contract with blood collection agencies that will apply to all blood suppliers, blood collectors, blood.
Claudia, Lynn Ewell had a comment in chat.
Thank you, Jim. So Lynn asks, are hospital collectors capable of contributing to surge capacity, interstate commerce and the like? Of course, many are probably not licensed for interstate commerce. But I know during CCP, hospital collectors did do a lot of work. I don't know how much we're talking about. I think it's an important question, Lynn. Thank you. And Sridhar says could apply to rather than will apply. Ruben's of BARDA.
Yeah, and I'm not sure if I have the right, that this is repeated a couple times, and I don't know if we've landed yet on specific terminology. You can feel free to direct me if I've not captured something.
So Jed, do you want to come on camera and say your comment?
Yeah, I just said BARDA obviously has a very successful model with the skin. They contracted with 2 suppliers. There's certainly more than 2 suppliers. So I don't think it's our job to tell BARDA how to contract. We want to allow BARDA the flexibility to have as big or small number of suppliers as they need to meet actual demand. So while I want to acknowledge that hospital collectors' contributions might be needed, it is absurd to mandate that they automatically be included if that need isn't there. So give BARDA the flexibility to contract as demand speaks.
What does the committee think about that?
I think it'll also, just one comment for me, depend on, I mean, it sounds like in the Zika model, which I know less about, it was also through, there was a contract with ARC and ABC, with CCP, also with ABC. And then in the CCP model, the hospitals did come under, it sounds like, the ABC. So it seems like, yeah, maybe we don't, I agree with Jed, like maybe this can be a little bit more vague with just what we kind of had in the beginning, negotiate a contract with blood collection agency and suppliers. And the model that we've seen so far with Zika has been ARC, ABC, and then ABC kind of lumps together or will incorporate many of the non-ARC centers or whatever's needed for that scenario.
Thank you, Suchi. So based on what Jed and Suchi and others are saying, do we want to keep the word uniform in? I see a shake of the head from Cassandra, I think.
I don't think we need to, sorry.
Yeah, I don't think we need to either.
I don't think we need to.
So we just let this be free market. Let this be that, I mean, I just don't want there to be chaos in negotiations that BARDA having to deal with 100 separate contracts. But Jed, you're right. I mean, this isn't our place.
Let them decide that, right? Just leave it. Yeah.
Yeah.
Delete a contract, negotiate with blood collection.
And I think in the last 2 examples, Zika and CCP, it wasn't with lots of individual blood centers. They were lumped under ABC. I mean, I think that's going to be likely how it is approached. But if we don't make it too restrictive, it does give a little bit more flexibility to whatever situation arises.
So do we need that second that could apply to all blood collection agencies and suppliers? Can we just make a full stop at
I think
Committee
so.
therefore recommends that BARDA under ASPR negotiate with blood collection agencies and suppliers.
Agree.
Okay, I think
Yes.
we've gotten through the first step unless others have a comment on that first clause. Great. Next is tightening up the idea of when this will apply. So during long-term public health emergencies to support the collection and manufacture of blood components to allow for a minimum 10% increase. Let's just deal with during long-term public health emergencies to support the collection and manufacture. Does anyone have any thoughts on how to tighten this?
I think there was a suggestion to take long-term out during public health emergencies.
There also, though, was a suggestion to take out public health.
During times of significant inventory shortage, or during times of current or anticipated inventory shortage.
Or it could be just as simple as saying a federally designated emergency. Because somebody's going to tell us there's an emergency and we need a surge. So we don't need to pre-negotiate what level here. We just need in principle that the government will support the collection, testing, and distribution above baseline. So don't limit us on the term to say federally designated emergency, and they can throw the switch and everybody goes to work. And then they turn the switch off, and then they're responsible for the dollar amount that's above baseline for everybody putting in that extra effort.
Lou, what about when a federally designated emergency doesn't involve blood?
Well, that's where they would tell us as an industry, a federally designated emergency that qualifies for our segment, right? So I would hope that nobody would say that because there was a mass flooding event in a low-lying area that the collection agencies would start collecting blood where none was needed. So I would look to the federal government to tell us that it's time to surge blood collection and distribution.
What does the committee think?
I would wonder what part of the federal government's going to make this designation.
I think that's fair.
I mean, is this Jim's office, or, you know, it seems a little, you know, a little broad.
Well, it is meant to be broad because they have to weigh in at this point and figure out where the funding and the actioning of any surge event, who's going to be responsible for that within the system. If there was, you know, as described before, in the event of a nuclear explosion and a mass burn trauma event, BARDA has pre-negotiated, due to the nature of the tissue, a surplus inventory that can be deployed. Because blood doesn't have a shelf life like that. Somebody in the federal government is going to be responsible for declaring to the blood banking industry it's time to surge. I don't know who that is or who to ask to do it. But I don't know if we really necessarily on the recommendation have to ask it. I think that could be a follow-up to a response from the government as to, okay, this is what we're thinking. What do you guys think of our response?
Should we have a sub-recommendation that OASH interpret a federal emergency and put this recommendation into effect at that time? And then Elisa.
Did anyone want to comment first on the OASH statement before I go? Okay, I'll just go. I wanted to circle back on the public health emergency phrasing. I just looked up, public health emergency. How would you define it? And here's a definition from the Chicago Department of Public Health. So a public health emergency is any adverse event, natural or human-made, that compromises the health of the population and has the potential to cause widespread illness. And then they give a whole bunch of examples, including, nuclear attack, chemical attack, infectious disease, and so on. To me, it seems like that phrase works fine just here. And it is going to occur regardless of whether or not the federal government recognizes the event as such. So is that important that we designate that the government recognize the event as an emergency or not? I just wanted to throw that out there.
My first response to that is there's funding involved with this. And so if a blood center decides that additional blood is needed, but it has not been designated, will they receive this different model of reimbursement for those collections? I don't know. What does anyone else have an answer for Eliza?
I don't know if this is an answer, but so this is Stacy. I keep looking at the during times of current or anticipated inventory, blah, blah. And I almost agree with Lisa and wonder if the wording should change to something. So if you started at during times of public health emergencies that impact the blood supply as designated federally, and then maybe you go to OWASH or something at that point. Because when you use that times of current or anticipated inventory shortage, I don't think what we want to do is allow blood centers to trigger this on just because it's a bad January. That's not the purpose of this, I don't believe. So it just feels like that public health emergency might be the right designation. So I said during times of public health emergencies that impact the blood supply as designated federally. I don't know if that's right, but.
I think that provides the context that sort of Lynn was sort of saying, like, what is the context of what we're doing as opposed to the other way around. So I think it calls attention to why we're saying this. I like it.
So we're simply saying that if there's a public health emergency and below we say, oh, actually, although I've just been nudged that we shouldn't be saying, oh, actually, we should be saying ASPR, declare to determine a federal emergency. So we're saying there's a public health emergency as declared by ASPR, and that this emergency has an impact upon the blood supply. Stop. That's what the statement would cover the times in which this recommendation would go into effect. And then I'll ask Glenn, then Susan, then Lynn. Is that your intent, Stacy, and what people are liking? Glenn?
Yeah. The emergency support function number 8 is part of the whole national emergency response system. So I don't think we need to worry about defining from our sort of bottom up perspective what is an emergency. There's a whole Homeland Security HHS superstructure to do that. And I guess you're referring to ASPR as being part of that, but I don't think we need to, as long as we can, the language is consistent with what is in that structure, we can go on.
So Glenn, are you saying that we don't need to, that the language we have currently is sufficient and refer back to ESF 8 or?
I would just, I'm not sure what the language is in ESF 8, but I would just, if we're just, I don't think we need to worry about defining what the emergency is. That's already going to be, that's been defined already in the HHS national response. So if we can just get the language consistent with that or refer to that, that would cover it to me.
Anne has put a link to the public health emergency declaration in the chat from
Yeah, that's
ASPR.
HHS's. I just thought it would be helpful. That's HHS's definition of a public health emergency. So.
Thank you. Susan? Susan Galil?
You're on mute, Susan.
Yeah.
Sorry, I was on mute. Yeah, I'm struggling a little bit to envision the scenarios that we're trying to address and whether they would all be considered public health emergencies or some other kind of emergency. I just don't know. And it sounds like, if we could go back to the proposal that we're talking about an emergency that for which we are, blood banks are unable to support the blood needs, and leave it at that without defining the specific declaration type.
Lynn?
Yeah, I want to echo Susan's comments. I think again, to pin it to declaration of public emergency, whatever the term was that was there before, is limiting. As you may recall, it took quite a while with COVID even before the declaration of a public health emergency was called. And if we're looking at it as an industry, seeing the writing on the wall to wait till that's declared, I think may tie our hands in a way that we will regret going forward. So.
Would it be that if blood centers, I'm just throwing this out, if blood centers see the demand increase, would their turning to BARDA for a contract be enough to stimulate this? Because if BARDA says there isn't enough there, then that shuts it down.
But I think that goes back to what Glenn Ramsey's comments were, that further down, I think there is an ongoing surveillance of situations which may impact the blood supply. I hopefully there are enough eyes on that that could then trip back into this recommendation to get it going. Glenn, I think that was your what you were indicating, right?
Right, thanks.
So how do we translate this into appropriate language?
This is Glenn Ramsey. That's one other little wordsmithing thing maybe is the sequence of the sentence. It says negotiate during the emergency. I think we really want to have this negotiation before the emergency.
Well, it depends on if this is a preventative measure or whether it's a activate it when it happens measure. I mean, there could be two parts to it.
Yeah,
There
true.
It could be an A and a B.
To respond to, maybe, I don't know, something like that. But in the skin model, this has been all negotiated way ahead of time. And
right.
So that's one model, I guess, and the other could be, hopefully some of this could be worked out before the emergency, I guess, is what I'm hoping maybe.
But this I mean, they did talk about frozen skin versus fresh skin. And of course, blood has especially platelets, has a serious shelf life. So BARDA can't support, or well, I shouldn't say can't, maybe this is what we're asking for, that BARDA support extra collections at all times, but that will lead to tremendous wastage. It's not completely parallel how to deal with skin collections prophylactically versus extra blood that's needed.
It could be though, Claudia, that they could put the mechanisms of contracting in place with certain organizations so that at least that piece could be out of the way at the time that an emergency arises and then could be activated immediately rather than go through 3 or 6 months of negotiation, which you don't have.
And what those specifics are, maybe infrastructural, right? That you have the supplies, there's a list of things, the people, more pay, all these different pieces so they can be activated within that contract that Ray's talking about. And they are the things that the hospitals are not going to be able to pay for, right? So it would be something directly at the blood center level, making those, making those preparative things to be able to respond appropriately. So it's like response preparation.
I like it. What do people think? So the committee therefore recommends that BARDA under ASPR negotiate with blood collection agencies and suppliers prior to public health emergencies that impact the blood supply. Do we need to then say as designated federally, or do we say, based on an HHS declaration, these contracts would go into effect based on a designated federally declared emergency?
I like that.
Can I just ask for some clarification here? Does this mean that the negotiations would happen prior to any emergency emerging? And would,
yes.
Okay, and is that a problem if, given that emergencies might not be predictable?
In my own non-business head, the way I'm envisioning this is that there would be a negotiation based on different levels of increased demand, but that would be up to the negotiations. What do people think?
This is Glenn. I was okay with or during, in prior to or during.
Okay.
I don't think it is a problem to put both of those in there.
Well, it leaves it open to have the conversation, the planning conversation. I mean, how did they get to, if we have a nuclear war, that we're going to pay all this money to put all this skin away when we don't even know who's going to survive? I mean, somebody decided that was important, but that they didn't really make them. What about who's going to have the blood supply for those people if they survive? And who's going to have all these other pieces? So somewhere along the way, people are proactively thinking about dealing. And this may be one arm of what we're suggesting, to be in that readiness mode to then go to the during the problem, because we can't predict all the different problems that could happen, and Zika being one kind, infectious being another, the whole country being affected. So
I second what Cassandra just said. Yeah.
Sridhar, then Diane.
Yeah, so then why do we need this recommendation at all? I mean, HHS has done this before. So during Zika, there was an emergency contract. During COVID, whether it was needed or not, there was something for convalescent plasma. So, I mean, based on the nuances of each public health emergency, HHS has reacted before. So why is there even a need for this recommendation?
Well, Sridhar, I'm actually surprised you're asking that because, as you've pointed out, the way Zika versus CCP was negotiated was very different. And
But this isn't really, this isn't addressing, I mean, the problem with CCP was that there was no data to suggest that that actually worked. So
this is addressing that there will be a different reimbursement model during times of extra surge, and that is not directly addressed yet. Am I answering your question?
Yeah.
Stacy?
So I wonder if I'm trying to wordsmith this, and Claudia, if this is a really bad idea, just tell me because you've got all of the experience. But I think we're focused on the negotiation first. And I wonder if instead we said something like, the committee therefore recommends that BARDA under ASPR prepare to respond to situations that require surge capacity of greater than 10% increase in the blood supply, that and use a reimbursement model for collection and manufacturing that is and we'd have to figure out that end, but I think what we're really wanting them to do is prepare in advance, right? And have a mechanism so they can just trigger it. And so by kind of changing that wording to prepare to respond to situations that require the 10%, we could then weave everything else in. And then maybe that would help with some of the other comments about why do we need this? And it's really to prepare us for that disaster where it's just impossible for us to respond.
I think that's very reasonable, what you've just said. What do people think? So the committee therefore recommends that BARDA prepare to respond to situations as you've written.
Needs to say greater than.
Do we
Real
need
trouble,
to,
real trouble arises when you're at 9.9%. Unless you tell them to round up.
we'll put that in as a subclause, round up.
So Claudia, my only comment was, this always makes you nervous when you say, okay, let's go. We have a 10% need. I think most blood centers will tell you we also need then to be able to prepare to have the supplies, whether it's the testing kits for a testing lab or the blood bags for a blood center, because most blood centers can't afford to keep, 3 months supply like they used to, or they can't get them if they could. So that preparedness is so important that in some way we're being allowed to prepare for that also.
That, Diane, is a very valid comment. It is not part of this now, though, because this is a recommendation simply saying that there needs to be a different reimbursement model during surge. That comment, your comment, speaks to stockpiles. And in the next set of recommendation, I believe that's touched upon, but perhaps that needs to be fleshed out further. But that's a supply chain issue. It's valid, though. Thank you. So are we comfortable with that requires surge capacity of greater than 10%? Do we want to wordsmith that? Or just say that impacts the blood supply?
Well, we talked about how we didn't really think, or some didn't think that 10% was really enough.
Mhm.
So, but then there was earlier that it said a minimum. It didn't say that that had to be, that was the place that you would start at. So I don't know if having a number makes it more powerful or not. It seems to, in some ways, make it have some, to the people who are reading it, have that we have like some kind of cutoff, but I don't know that we really know what that cutoff is.
But if the 10% were there, would this have applied to the situations with regard to CCP and the Zika supply in Puerto Rico? Did those cause an increase of greater than 10% in the blood supply, I assume nationally? Or were those specific issues that addressed needs within small community? Because if this doesn't address where we've actually experienced emergencies as a cutoff, I would say be more generic and let the particulars of the moment and the situation drive the decision.
So simply leave it as surge capacity that impacts the blood supply. That has an impact upon, if we're going to be using English properly.
Like it, like that edit.
Yeah, I would agree. I don't know what 10% above what, the summer doldrums or October. You know what? To me, that's a meaningless number and not going to be very helpful in this, because I don't know what the denominator is.
And until we expand circulate, we really don't know what the denominator is. Kat, BARDA is in there twice in the first line. Thank you.
We want to have anything that says, you know, that this is implies regionally and nationally. So impact upon the blood supply regionally or nationally. So I'm just throwing that out there if we want to. This isn't just national, but it's so dependent on the situation. And it could just be more of a regional issue.
I'm going to go back, Suchi, to a comment I made earlier, which is an increase in demand that cannot be met with redistribution of blood, available blood, or that cannot be met with the current blood supply. And so a regional problem may be so large that even if every blood center starts shipping to that site, it's not sufficient, and this will kick in. So to put that into words, surge capacity, surge capacity that cannot be met with current available inventory.
Or current infrastructure inventory, yeah.
Capacity, maybe.
Thank you. And therefore has an impact. Do we need that? Marilyn?
Two comments. One is that we're assuming that the recommendation will be for BARDA, basically to be part of making the definition or recognition that there's a public health emergency. But if you have, for example, what happened with COVID, where it was a public health emergency that, Sridhar, correct me if I'm wrong, but it was announced basically by the CDC, and then there was a need for drumming up CCP, that then it also involved other agencies within HHS. So is it appropriate to limit everything to BARDA, or is it because BARDA would be primarily involved with getting the additional blood supply?
As I understand it, BARDA is what funds it.
Okay,
And
so
somebody mute, there's some background.
Okay.
Thank you. Go on, Marilyn, sorry.
Under funding, okay, but this statement would not restrict the definition of a public health emergency only to BARDA, but basically any agency within HHS, for example, could be involved with that definition. Right, there's nothing there to limit it, right?
No, as I understand it, this is just a recommendation that BARDA negotiate contracts so that if there is a public health emergency declared by CDC or any other agency, as long as it fits within, you know, what Anne has given us a link to, that this would apply.
Okay.
But if that's not clear, then we need to make it clear.
Where to public health emergencies? Do we need to say with public health emergencies determined by HHS, or would we need to add something of that nature? Just leave it as HHS, not necessarily one agency versus another. Okay, and the second is in terms of, and again, this may be wordsmithing, but where the importance of getting all the contracts established before a public health emergency can occur so people don't end up scrambling, whether maybe some of the wording, and again, this is wordsmithing, to negotiate with blood agencies, maybe something about implementing the contracts that were established prior, just at the standard, so that it's understood that there is an ongoing standard contract that can be just pulled out when needed for a public health emergency. See what I'm talking about is like to implement so that people are not running around trying to quickly at the last minute try to get contracts going, something of that nature. See where it says negotiate with blood collection agencies and suppliers prior to or during something about that they can then implement the contract. Here, the contracts would go into effect, right? So just to establish that these contracts would be in place so that there's nothing like last minute emergency to try to get things done. Okay. Yeah. Thank you.
Thank you. So, as I see it, the first sentence would read, the committee therefore recommends that BARDA under ASPR prepare to respond to situations that require surge capacity that cannot be met with current available capacity. We haven't mentioned blood in here anywhere. The committee therefore recommends that BARDA under ASPR prepare to respond to situations that require surge capacity of the blood supply that cannot be met with current available capacity and therefore has an impact upon the blood supply. Maybe that needs wordsmithing. These contracts, BARDA would negotiate with blood collection agencies and suppliers prior to or during public health emergencies that impact the blood supply. These contracts would go into effect based on a federally declared emergency. Stop. With a little bit of touching up because I think there's some awkward phrases in there.
I think you can remove the and therefore.
Sorry, are we also removing this whole phrase? Let's see. Oops. Sorry.
Did we leave out the preparedness part? That part that we were talking about earlier? I don't know. Am I missing that somewhere?
Let's see.
It was somewhere. where we're sort of saying that we would want prepared and during the problem?
That would be this, blood collection agencies and suppliers prior to or during public health.
Oh, you got
emergency.
the prior to. Okay, thank you. Sorry. It's a lot of moving going on. Okay.
Sorry about that. Yeah.
No,
Alexandra?
you're doing great.
We still need a sentence about the reimbursement for the collection and manufacture.
Yes, we do need that, but they require they require a surge in the capacity of the blood supply that cannot be met with current available.
Yeah,
Would it be
another
inventory, current available inventory or current available capabilities? Is the word inventory right?
Maybe capabilities.
or maybe another way to think word is prepare to respond to situations that requires a rapid increase in blood collections that cannot be met with currently available capacity.
I'm so sorry. Can you say that again?
It's just an idea. I don't know what others think, but it's prepared to respond to situations that require, I put rapid, but require a rapid increase in blood collections that cannot be met with currently available capacity.
Yeah, I like the word collections instead and having then capacity.
Yeah.
I like that.
Public health emergencies. In the agencies and suppliers prior to or during public health emergencies. And then we need to bring it back to the reimbursement model.
So Claudia, could you say these contracts would go into effect based on a federally declared emergency, and reimbursement shall be for collection and manufacturing rather than transfusion of blood that is deemed needed during the emergency? I don't know. We have essential down below. I'm kind of just taking that last sentence. I don't know if essential's right.
What do people think? And I'm particularly interested in the ex officio members who have been concerned about the reimbursement model. Any additional comments?
Someone in chat put, do we need to add distribution?
I think we should add distribution because that costs money.
About collection, manufacturing, and distribution of.
Yeah.
Did we do it? Are we ready to vote?
You want to have one last read through just to make sure it
Please.
sounds correct to everybody? I can read it if you'd like. The committee therefore recommends that BARDA under ASPR prepare to respond to situations that require a rapid increase in blood collections that cannot be met with current available capacity. BARDA would negotiate with blood collection agencies and suppliers prior to or during public health emergencies. These contracts would go into effect based on a federally declared emergency, and reimbursement shall be for collection, manufacturing, and distribution rather than transfusion of blood that is deemed essential during the emergency period. I would suggest a comma right there.
I have a minor comment. Reimbursement shall be for the collection, the manufacturer, and distribution, just to keep it in the same format.
I was going to say you could lump all three of those words into just call it provision. And you have so many words in this thing, then just say provision for the provision of blood rather than defining all the steps.
Actually, I think we don't want them to have to provide it. We want them to manufacture it and get paid even if they don't.
You're providing it to hospitals. That's what we do.
Yeah, but right,
But not,
I think we want them to be paid if they have it in their inventory. That's what my understanding was of the request. Maybe I'm wrong in my.
No,
No,
you're
that's my
absolutely right,
understanding.
Susan.
I know it's a lot of words, but I do think it makes it clear what we're saying by saying those three things.
Whatever.
I don't want you to just give
That's
it.
that's the editor in Paul. Reduce the word count.
No, this is very long and unclear, and good luck.
Thanks, Paul.
All the material down below comes out, I assume, yeah.
Okay, aside from Paul's ringing endorsement, what do people think?
I will support it just so we don't have to keep talking about it.
Yes. Any other comments? May we, I motion for a vote.
Second.
All those who are in favor of passing this revised version of the recommendation?
Aye.
All those opposed? We've now gone threefold over what we did in the 57th. Congratulations, everyone. Let's quickly move to recommendation 4. We have 2 minutes, so I don't know if we'll get to it. If we do not, we will put it at the end of the second set and see if we get to it. The committee therefore recommends that Secretary Becerra fund additional public awareness campaigns, including funding for data analytics to increase the donor pool and determine effectiveness. With the revised revision, these funds should be distributed to blood centers for local campaigns. Any comments? Michelle?
Might be a legacy hand. It was up before.
Okay, thank you. Any other comments on this revised version, which is under consideration?
I would take the specific name out in this political environment.
Yeah. The Secretary of HHS?
Yeah.
One comment is, do we want to say these funds can be distributed instead of should? I mean, I think it's, if there's a national campaign, that's okay too. And I think the comment we saw from ABC and ABB was that they support that, but they're also saying that the funds can be available locally too.
I'm okay with that. Any other comments?
Does the Secretary of HHS have a mechanism by which to award blood centers locally for these kinds of campaigns? Or is that something they would have to create in order to allow the distribution of funds?
I don't know. It's an important point. Does that need to be in the language of the recommendation?
I don't know, maybe Jim has an answer there.
Well, something similar to like the Giving Equals Living campaign is what HHS funded, depending on what kind of campaign is needed. Would certainly be up to the secretary's discretion on what needs to be put forward.
If we get into this is difficult because there are so many different blood centers, and how to distribute that money, I don't know how to begin. And I don't know that it's appropriate for us, but I see Jed's comment and I appreciate it, that local blood centers know their market and know how to market to their donors. So I like the idea that the funds would be distributed locally, but I don't know how to put it into language so that it would be done in a fair manner.
Well, I think what Jim said is that it would be up to the Secretary of HHS to make that determination. I was just bringing it up because, I've had situations where, there are recommendations and pushes for NIH to get funding, and then they don't necessarily have a mechanism to distribute it. You have to set up a grant review process, or is it some kind of a contract, et cetera, et cetera, et cetera. I agree, Claudia, you don't want to get into those weeds, but it could also be the point that we recommend something that it's impossible for them to implement.
I have a comment. It seems like the comments that we received were advocating for the local distribution. And so it seems like we should change the word can to the word should.
Yeah, I mean, I guess it's just different. I'm fine if everyone else like should, that's okay. I think national campaigns could also put, I think that comment was supportive of the national campaigns, but if everyone is like should better, that is fine with me.
What if people, sorry?
The data showed that the local campaigns, based on that comment, were more successful. There must be a mechanism to do it because that would have come through BARDA before. So I like should.
Any other comments besides can and should? Now. Let's stick with
when we talked before about blood centers being a little bit too narrow, similar language in terms of blood, blood collection agencies or et cetera, where we had before. The example we're shown here is ABC.
So the funds would be distributed to the blood collection agencies who would then distribute it. That's fine.
Did I capture that correctly? Is that what the change was?
Yeah. Is that correct, Glenn? Thank you. Any other comments? We're already into our break time, and I don't want to take that away from people. Do we feel that this can be moved for a vote?
Yes.
I move for a vote.
I second.
All those in favor of the revised version? Sorry, yep, yay, hey.
Yay.
All those opposed? Okay. We have passed 4 recommendations. Congratulations, everyone. Thank you. As I said, it's on the schedule. We are already into our break period, but let's give ourselves 5 minutes and we will dive into the second set of recommendations. Thank you, everyone. Let's give 7 minutes, okay? I'll see everyone at 12 or at 7 minutes after the hour.
Produced by the U.S. Department of Health and Human Services.